Respected faculties, Dr. K. Jayaprakash, sir of Department of Cardiology. I am presenting a case of chest pain on behalf of M4 unit. So it was a 70-year-old female coming from Changanasheri who is diabetic for 2 years on OHA, present with complaining of mild central chest pain for 2 days, which was not associated with the sweating or radiation, and was admitted via cardiology involved recurrent chest pain. There was a history of shortness of breath for 1 day and had heaviness of chest associated with that. She was apparently normal except for 2 to 3 episodes of shortness of breath and chest discomfort in the past 2 years after strenuous work, for which she never sought any kind of medical attention. No history of palpitation, syncope, PNT, pre-syncope or orthopnea. In the ward, she was symptomatic and was advised not to sit up due to an incidental echo finding. On examination, she was conscious, oriented, moderately built and nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, but she had bilateral mild pitting pedal edema. Vitals were stable with a BP of 120/70 and JVP was elevated 10 cm and prominent AV was seen. And CVS examination was normal with no clinically important murmurs. All other systems were within normal limits. And hemogram was normal and trophy was also negative. ECG showed right atrial overload features. Chest X-ray was also normal. And the routine echo showed a large atrial mass. So, to summarize, it was a 70-year-old female who was apparently normal, came with complaining of mild intermittent chest pain, shortness of breath and chest heaviness with JVP elevated and bilateral pitting pedal edema. Routine echo showed a right atrial mass. Possibilities considered were right atrial thrombus, right atrial myxoma or secondaries to the heart. So, we proceeded with echo. In detail, which showed a very large mass in the right atrium, as you can see here. This is the 4-chamber view in which you can see this is the right atria, this is the left atria, this is the right ventricle, this is the left ventricle, and this right atria is filled with a very large mass which is almost touching entering the right ventricle and reducing the flow to the right ventricle. So, when we found a right atrial mass in the echo, as you can see here, the mass actually it was very large with 4.77 centimeter into 7.27 centimeters, and in Doppler we could see the mean pressure gradient was 13.17, which is too high and showed a functional tricuspid stenosis. And the another finding was IVC was non-collapsible and it was about 2.8 centimeter. And in the video also we can see the mass was coming and it was coming out of the IVC as. This is another video which shows, you can see the mass coming out of the inferior vena cava. So the mass was at the junction of inferior vena cava and right atrium and extending and almost filling the right atrium. So coming back to the discussion, so as we saw, the inferior vena cava was dilated and the pressure was high on that side. So the cardiac metastasis present a unique disease cause in renal cell carcinoma as well. So in renal cell carcinoma, venous thrombus can be seen, and the level 4 in the classification, it can be an atrial tumor thrombus. To rule out embolization of tumor fragments or tumor-associated thrombus and the possibility of renal cell carcinoma, we went for further imaging. So that imaging showed, as you can see here, this is the CECT abdomen thorax with CTPA that we took, and this section shows a filling defect here. This is the right atria. Here you can see a filling defect. This white part that you can see, the hyperdense part that you can see is the contrast that is being filled, and this part, because of the tumor, it is not getting filled, that it can be seen as a hypodensity. This is the coronal section. Here also the right atrium you can see a filling defect which shows a large tumor. So the CSC result came is as focal lesion in the right atrium extending top right ventricle, cardiac thrombus, cardiac mass, and the CTPA was absolutely normal. The coronary and we proceeded with coronary angiogram and normal coronaries were found. And she was posted for emergency surgery by CTVS. It was a friable mass starting at the junction of IVC and right atrium. So the possibilities considered were elastofibroma bar myxoma, and histopathology. The mass was taken in toto and sent for histopathology. And when the histopathology report came, it was atrial myxoma. The histopathology was consistent with atrial myxoma. Section shows a neoplasm composed of cells arranged scatteredly and in few linear cords in a myxoid stroma. So individual cells are stellate, spindle, polygonal cells with moderate eosinophilic cytoplasm. So hyperchromatic nucleus and inconspicuous nucleoli, etc. were seen, and occasional multinucleated cells and bizarre cells also were seen. So all these were consistent with myxoma atrial. So in the discussion part, our case is important because of the atypical size and the location of cardiac myxoma in the right atrium. So atrial myxoma and other cardiac tumors. The cardiac tumors, they can be broadly classified into those that arise primarily in the heart and those that reflect metastatic disease from a distant primary source. So primary cardiac tumors can be further divided into those that are pathologically benign and those that are malignant. So overall, primary cardiac tumors are relatively uncommon, whereas secondary involvement of the heart or pericardium occurs in as many as 20% of patients with end-stage metastatic cancer. And the primary intracardiac tumors, they are very rare, and approximately 50% are myxomas in primary intracardiac tumors. The majority of myxomas are located in the left atrium, as we all know. So, and have variable clinical presentation as well. So, if we present a case of large myxoma in the right atrium, which is an uncommon location for this type of tumor. Primary intracardiac tumors are rare and 75% are benign, and approximately 50% are myxoma, which have an incidence of 0.0017% in the general population. Histologically, these are real tumors derived from multipotent mesenchymal cells of the subendocardium. Myxomas are located in the left atrium in 75% to 80% of cases, almost always present with signs and symptoms of mitral valve disease or thromboembolic events, since left atrial myxomas are common. Right atrium constitute only 18% of atrial myxomas. Rarely in the aorta, pulmonary artery, ventricles, vena cava, or even other organs can have myxomas. Close DDs are rhabdomyoma or a thrombus. Myxomas affect patients with a wide age range, from old to young, so 15 years to 80 years. There is a female predominance in the sporadic form. Myxomas are usually pedunculated, solitary, and sporadic. Three types are there. So familial variety is only 7%, and when it is familial, it is autosomal dominant syndrome. These familial forms have the following characteristics, that is, it affects young male patients. The sporadic variant was more common with females. Here in the familial type, it is more common with male patients and will be of multiple, and risk of recurrence after surgical excision is high with familial variant. The microscopic features of myxomas, it is characterized by a myxoid matrix rich in mucopolysaccharides, in which polygonal cells with an eosinophilic cytoplasm can be detected. The polygonal cells may appear as a star, that is stellate cell, or a nest shape, or maybe multinucleated. Microscopic characteristics including mitosis, necrosis, or pleomorphism are usually not detected or is eventually present as mild findings only. So signs and symptoms caused by myxomas are atypical and highly variable according to the size, mobility and location of the tumor as well as physical activity and body position. Patient symptoms may have an asymptomatic course or progress with thromboembolic events that may even lead to sudden death. So it can be an incidental finding or the patient can present with peripheral or pulmonary embolic features. The classical triad found in patients with cardiac myxoma are obstruction of blood flow, constitutional symptoms, and thromboembolic events. Constitutional symptoms include fever, arthralgia, etc. The obstruction of blood will lead to intermittent heart failure. So similar to systemic non-specific flu-like malaise symptoms can also be seen. That is low fever of long duration, arthralgia, anorexia, and thromboembolic events. So in right atrial myxoma, it obstructs right tricuspid valve, causing signs and symptoms of right heart failure. Peripheral edema, ascites, hepatic condition, syncope may be the findings. And also in X-ray, you will be able to see a right atrial enlargement, and in ECG also right atrial enlargement findings can be seen. I sincerely thank Department of Cardiology and CTVS department regarding this case. Detailed echo findings and the timely intervention by the CTVS department saved the life of the patient. We again saw the patient when she came for review, and she's asymptomatic and no further complications for the surgery have occurred till now. I sincerely extend my sincere thanks to Dr. K. Jayaprakash sir, who found time in his busy schedule to attend our club. Thank you, sir.